absolutely delighted to have as our guest today Jon Barrick, past president of the Stroke Alliance for Europe, SAFE, and current SAFE patient voice ambassador. For those of you who are not familiar with the Global Hub, very quickly just to mention to you that we are a relatively new alliance of non-for-profit heart patient organizations around the world. And our whole purpose in life is to provide a platform for those living with or affected by cardiovascular disease. And at center of our approach is to build the community of cardiovascular patient organizations. And we're doing this through building special interest groups or councils, patient councils, as we call them. Currently, we have councils in the areas of heart failure, heart valve disease, cardiomyopathy, emerging councils in cardiodiabetes, emerging working groups in women and heart disease, and we have a working group in ASCVD. And this is the way in which we propose to grow and develop our alliance so that we eventually get to a point where we have a truly global network of patient advocates. It's very important, of course, that as we do this, we collaborate and work with as many organizations with a similar focus and interests as us, and you'll see some of those listed on the slide. There are three pillars to what we do. First and foremost, it's of course about cardiovascular disease awareness. Advocacy is central to our pillar, about providing a voice for those living with or affected by cardiovascular disease. And the third part of what we do is the Global Heart Hub Academy. And this has come about in response to the realization that despite the many patient organizations that are engaging in advocacy, there is a huge need to support patient organizations in terms of their advocacy capacity and capability. And to this end, we're developing a program of capacity building, training, and advocacy development. The Inspire Speaker Series is really an opportunity which we provide about every 2 months, where we have a conversation with someone who, through their lived experience or through their work experience, have very valuable lived experience, either with a disease, a condition, and or an experience in advocacy, whether as a carer or as one with lived experience. And the idea is to have a conversation with these individuals, and through that conversation, hopefully some of those of you who are listening will be inspired by what you hear, will be motivated by what you hear to take up the mantle of representing the voice of those living with or caring for those with cardiovascular conditions. Today, our guest is Jon Barrick. Jon is a former president of the Stroke Alliance for Europe, which is the acronym SAFE, former CEO of the UK Stroke Association, board member of the World Stroke Association, chair of the Neurological Alliance Coalition, former director of services at the UK Royal National Institute of the Blind, and currently he is a patient voice ambassador for SAFE. So I'm looking forward to chatting to Jon about his experience. Before we get into the conversation, can I just mention a few practicalities? Instead of the chat function, we would encourage you to please use the Q&A function. And please do share your thoughts or put in your questions. We'll hope to address some of those, even though we only have 1 hour, and we're going to keep to that hour insofar as possible. We'd also ask you to complete the post-event questionnaire, which you will receive within 48 hours of today's recording. And this session is recorded, so you will have the opportunity to listen back if you need to do so. And we'd encourage you also, when you do receive the recording, that you might share it with others who might have an interest in this. But if you would complete the post-event survey questionnaire, so that it will help us to continually improve these sessions. And I point out that the webinar is being recorded, and it will be available on the Global Heart Hub website. So straight into our conversation with Jon, or should I say Dr. Jon, because I was just reading your biography here, and I see that you received an honorary doctorate in recognition of your voluntary sector leadership, Jon, from the University of Bath in 2017. And also I see in your credits that you actually were listed in the top 5 of Britain's most admired charity CEOs, first in 2006 and then more recently in 2013. And I can understand, after looking at your reading through your biography, why this is the case. I think what you have done in your life of advocacy, Jon, is just absolutely incredible. And I thought that just in the context of today's conversation that we might actually literally just go through your biography, because it prompts so many questions, and it's really inspirational. So can I start by asking you, I suppose, how you got into advocacy in the beginning, health advocacy, because there are many aspects to this, but even just a top line intro just to get us going.
Well, thank you, Neil, for those kind words to start. I came from a humble background, but I was born into a family where my older brother had meningitis and then had a lifetime of epilepsy as a consequence. And my younger brother was born with a cleft palate, which led to a whole series of issues. So I was born into a situation where you know, with love for my brothers and family, I wanted to do the best. And my father was a great advocate for justice as well. And so I think I inherited those values, as it were. Very good.
And then you from previous conversation, which you started your working life actually in the civil service, effectively. Will you tell us a little bit about that and the homeless area?
Yeah, so well, I started, obviously, like all young people, you can be quite idealistic and you're looking for something that you can get started on in life. And so first of all, started doing anti-poverty work, but that then meant that I went into trying to help in terms of the homelessness crises that were occurring in Britain because of the sale of public sector housing. And it meant that many disadvantaged groups who had gone into public sector housing before could no longer access that housing. So homelessness became a problem. And I wanted to go in and see if I could be part of the solution.
And the part of the problem, from what I recall from chatting to you, was that there was actually a sort of a line drawn in the sand, so to speak, that people with disability were not eligible. Is that right?
Well, up until a certain point, people with disabilities had access to public sector housing. But when public sector housing was being sold off, then those lines had to be drawn, and it meant that certain people who would have got access to housing in the past were now on the wrong side of that line. And one of those lines was that people who were partially sighted or had sight problems, blind, whatever, or were no longer necessarily eligible to get public sector housing.
So discrimination on the basis of disability, clear as that, yeah.
I think that they would say the powers that be would say that they were just refining their tests as to who could get access to things.
I see. But that took you into the Royal National Institute for the Blind.
It did, yes.
Yeah, and that was, I guess, a turning point, really, in the sense that you were moving from the comfort of a civil service career for life into the not-for-profit world.
Well, it never felt very comfortable, I have to say, dealing with homelessness. There was a lot of difficult things there, but yes, I moved into the voluntary sector, largely with the initial aim to start off with, to set up campaigns and advocate against the changes in legislation that were going through. And that's really where the start of campaigning, as it were, against the system started for me. It was good to be doing it within an organisation that had resources, that had respect, that was known to the public. But of course, later on in my career, if you like, you could say that I was working in areas where it was very small organisations with no awareness and no resources. So I was lucky to start in a big one.
Yeah. And actually, that's something we'll come back to, because it's a very important topic for all of us in the world we're in, because most patient organizations don't have the resources that ideally they would have. So we may come back to that. After, I think you spent about 14 years there, your next move was to the National UK Stroke Association. Is that correct?
That's right, yes. And when I went there, I don't know how aware people are, but there's 4 countries that make up the United Kingdom. And the Stroke Association at that point operated in England and Wales, but not Scotland and Northern Ireland. And that meant that there were certain difficulties in trying to develop fundraising on a UK-wide basis and all sorts of other things. But importantly, there were different things that were going on in each country. And, you know, you couldn't necessarily take the learnings from one country to another if you were separated.
Yeah. When I read here of your achievements during that period of time, it's absolutely staggering that the charity grew threefold. By the time of your retirement in 2016, the income was over 37 million. You had over 10,000 volunteers, a staff of over 800. These numbers are, for most of us, I imagine, in the patient advocacy world, just absolutely unbelievable. And I'm just curious to know how you did that. How did you drive that growth? Obviously, you were starting from a much higher base than and probably most of the people on our call today. But just talk us through, you know, strategically how you did that. What were the challenges? What were the learnings?
Well, I think that the most important thing is that one starts with passion, with energy, with getting a group of people together who have a clear conception of what you're trying to do, and work out a route forward and then pursue that route. I think most of us in our lives, we're knocked from one side to another by just living and getting along with things. But in terms of trying to build an organization, you need people, and you need people around you, and you need to empower more and more people to get involved in things. I've noticed through what I've been doing that there are certain groups that someone is a leader and they're dynamic, but they don't delegate enough things. They don't give the people around them the chance to get involved and to shine and to show what they can do. So right from the start, it was being very clear about what we needed to do and to let everybody shine within the organisation, volunteers, staff, people who had strokes needed to be put centre stage so they could tell their stories. I could go on into how you run public campaigns, but you know, lots of organisations talk about if this happens, these many thousands are going to die and all the rest of it, something's got to be done. And you know, we forget those things about numbers. Numbers don't stick in our heads. They're too big. What we do remember is the stories of people overcoming something, or the stories where people didn't overcome something, the stories of families that have been wrecked because of things that weren't done when they should have been done. These are the things that stick in the mind, not only of the public, but in the politician's mind. If I can say, Neil, we had a great coalition with the medics in the early days when I was at the Stroke Association, because there was no national stroke strategy in England. And that was a terrible thing, because since 1985, we'd known that stroke units make a huge difference to the numbers of people who survive, or the numbers of people who actually make recoveries. So why wasn't there a national stroke strategy to put in place these units in hospitals? And the medics fantastically had done lots of research, had lots of proofs, lots of evidence, if you want to call it that. But what was needed to push all of that over the line with the politicians was the fact that emotion had to be put into these arguments as well. We had to galvanize a situation where the public were beginning to say, well, this is terrible. This is terrible that these things are not being put in place. And the only way really that you can do that is by making the public aware of the stories of ordinary people like themselves who have not had justice, or where there's been inadequate provision which has led to problems for people, because there but for the grace of God go you or I. And you have to get people around those stories. So stroke survivors actually play an absolutely key role. And I think that's the case with most, if you like, medical-based campaigning. You cannot do it by evidence alone.
Right. And at the time when you joined the Stroke Association, like in a one or two sentences, could you tell us what was that organization about at that time? Because clearly later on, the stroke strategy was a big part of what you were driving. But at the time you joined, what was it? If there was no strategy, what was the main purpose or goal of the association?
Well, there was a strategy, and the strategy was to make sure that there was a lot of research that was being done into how to deal with stroke, into how to deal with the consequences of stroke, to create the evidence base, to persuade the government that they should be doing more, and so on. So the reality was that the authorities, if you want to call it that way, were not funding research medically into stroke. If nothing's known about something, then why would you fund something? So somebody has got to kickstart research and start getting results. Once results are being got, then people will fund it. So the Stroke Association were really at that point coming out of a period of having been the only organisation that was really banging the drum for stroke research. It was, all that work was done exceedingly well, and a huge platform had been built through that research. But the time had come where things needed to be moved on more into the public domain, more into advocacy, more into campaigning to actually move things forward. And then, of course, one hoped that research funding would continue to flow as you got more public awareness, as campaigns were more successful. So it was not that was the wrong strategy beforehand. Yeah. It's just that you look for moments when it's the right time to actually change course a little bit, reinforce a different way of taking things forward.
So the origins then were largely around research, and then subsequently moved into advocacy, and that was around the National Stroke Strategy, which you had a major role to play in. And I think your efforts were central really into achieving national stroke strategies. And again, we might just touch on like what are the drivers of success there again in a few minutes. Can I just now come then to the Stroke Alliance for Europe? So that's taking the national work that you had done now to an international or European level. Just tell us a little bit about SAFE, its origins and its aspirations and its achievements to date.
Yeah. Well, at the same time as the Stroke Association in the UK was coming out of the the foothills, as it were, of stroke research. There were MEPs at European level who were aware that stroke needed to be dealt with in many European countries. It was something that there were solutions to, but these issues were not being looked at in all countries across Europe. Now, there were some that were more in advance than the UK, but there were many that were well behind even the UK at that time. So these MEPs got together and they called for patient advocacy organisations to be created. And they facilitated a meeting of the 6 or so patient advocacy organisations that did exist within Europe to come together and actually band together to begin to influence the European Parliament and to look at ways in which they could support each other to create patient advocacy in each country of the EU. And that was how SAFE started. Just a small group of organisations, only 6, many countries without any advocacy going on at all.
Right. Now, it's interesting. I'm very interested in that piece because it's very close to the direction of travel, if you will, of the Global Heart Hub, which started out as 6 or 7 patient organizations. We now have over 70 internationally. But what I'm interested in is you mentioned that the impetus was coming from the politicians to the patient organizations, but I'm assuming though that was driven, it wasn't just a group of politicians of their own volition decided to do this, or was it? Like, what was the origin of them coming together, the politician at the political level?
Yeah, I think that what we've done, if I can give the example of the Stroke Association here, we actually did research on politicians within the UK government circles, and there was also research that had gone on amongst other organisations across Europe on the MEPs. What were their backgrounds? What were their influences? And we, of course, identified quite a lot of MEPs or MPs in the sense of the UK who had stroke in their life in one way or another. It might have been their mum, their dad, their brother, their sister, maybe someone within their family. And we approached those first as people who could be expected to support the notion that more needed to be done around stroke. Of course, many of those people might have been politicians, but they had also experienced the inadequacies of the system itself with regard to their own family. So they had an incentive, just as anybody does in society, to say, this is not right. Something needs to be put in place. Something needs to be done. So it was that interaction, I think, between doing a little bit of research about who are the politicians who are most likely to be responsive, drawing yourself close to them, drawing them closer to you, and then beginning to sit down and say, well, who else do you know who might join some sort of interest group on stroke within your Parliament or European Parliament in this case, who could use their position to create a noise about stroke and about the fact that something needs to be done. And that's what happened. There were a number of leading politicians who said, yes, we will take this role. We've experienced inadequacies ourselves, and we would like to see that eradicated. Interesting.
I could talk for ages around just listen to you about the various roles you had and the impact the work you've had, but conscious of time and also conscious of the interest of those who will be listening to this. If I can sort of dig into some themes that would be relevant to people working in patient organizations and in advocacy. So if you take, for example, the area of funding, okay? So based on all of your experience to date, if you were speaking to a group of patient organizations now who are struggling to try and find the resources to do the work that they want to do, what would your sort of top tips be, or what would you be saying in terms of what's the best way to look at sustainable funding from your experience? Just a general overview.
Okay. Well, the first problem we've all got is that there are different cultures in different societies, different countries. So ways of fundraising in one country may not be relevant to another. But there are a number of places that you can go to look for funding. Quite often there will be schemes that are coming from commercial organisations, organisations that have an interest in something being done about a particular condition or about the inadequacies of a healthcare system and wanting to see broken bits repaired and so on. I've never adhered to the view that commercial organisations are the enemy of patients. I think that is completely incorrect and the wrong place to start from. You have to understand that there will be organisations that overlap with you in terms of mutual interest, and you should try and sort those sorts of things out. So, for example, in the early days at the Stroke Association, we formed quite a few partnerships with organisations who were building scanning machines, because if there were more stroke units, then there would be a need for more scanners. But we could not get the government and the medical system to agree to more stroke units unless they could see that they could afford scanners to put in those units and so on. So yeah. I'm not saying that we helped to broker any of the negotiations that went on, but we were basically pushing everybody to get round the table. And we were quite prepared to take any support that would come from the government, and we were prepared to take support from the various electronics and electrical medical companies to pursue our goal of getting stroke units to cover every area. You know, I don't think we compromised anything in any way. Yeah. Other ways, of course, that are very important. And let me just say, we never actually only took money from one company. We took them from many different companies, so no one company could determine what we said. Another issue is actually trying to raise money from all the people who have been affected by your medical condition. Now, I'm not just talking about people who've been patients. I'm talking about their friends, their family, the work friends of all of these people. Is there ways and means that you can encourage those people to either maybe pay to be a member of the advocacy organisation, or to maybe make contributions on a regular basis? Or there are things such as weekly or monthly lotteries that people might be prepared to put some cash into. In many countries, you have people doing extraordinary things such as running long distances or swimming, or even sitting in baths full of cold baked beans, or all sorts of extraordinary things. Yeah. I mean, I think a little while ago we had the ice bucket challenge, which raised huge amounts of money. And now with the possibility of trying to push these things through social media, there's an opportunity to get things out. You know, my experience has been that you're better off starting with people who are close to the cause than trying to just activate the general public, because if the general public don't know about your cause, they're not going to be as likely to help you.
Yeah, I think certainly at the level of national patient organizations or even regional patient organizations, fundraising tends to be part of their mix along the lines that you've described. you have referenced there industry funding, which increasingly is a source for patient organizations. And I think your points are well made there around, making sure that there's an arm's length relationship, and that there's multi-industry funding. I think that they're very important messages. From the point of view of, again, an organization setting out, you spoke about, the importance of having people that are, passionate about what they do and so forth. Any views on how you attract volunteers into your organization? Now, whatever skill set you're looking for, bringing volunteers is always a key part of your growth. Any from your experience, what are the key things you'd be advising about how you attract and retain volunteers?
I think it's fairly similar to the sorts of basics of fundraising, which is to start with the people who are around your cause, who would understand what you're talking about and how it's affected people. To volunteer, normally most of us have to have an emotional catch, an emotional attachment to something to do that volunteering. So to just go into the general population and think you're going to attract volunteers doesn't always cut it. You need to start with the friends, the family, the workmates of people who have been affected by something. And, if you gradually build up a whole group of people who are around your organization, they should be the people who then bring in other people. I'm not a great one for believing that, something that's organized, advertising in social media or papers actually brings things. People buy people. It's people who persuade other people to do things. I'll give you an example. The child who comes home from school and says, "Mum, we're collecting some money for this at school." Now, mum has had no contact with it at all, but she loves her child, so she'll give her child some money to take back to school. So it's those people connections that make things happen, and you have to work through those people things. Just an aside on the fundraising, a third of our money at the Stroke Association came from people who had had some dealings with the organization, and when they died, they'd left some money in their will or their legacy to the Stroke Association. And that's one of the ways that we built up our income stream over the years, because the more people who were involved with us, the more people left a little something to the organization when they're passed on. So it's all about people. And at the end of the day, you start with ones or twos. Those ones or twos become 3 and 4s, and each of those 3 or 4, if they recruit another 2, then they recruit, and then it grows. It grows out like that.
Yeah. It's a pyramid. Back to the topic of campaigns, and I mean, this really is fundamental to any advocacy initiative. Virtually every patient organization has a mission to change something to make things better for others. In your experience in campaigning over the years, what advice would you give to patient organizations who are trying to address things? Let's start at a national level. So nationally, there are unmet patient needs. What are where's the starting point, and what are the key sort of indicators of success?
Okay, well, my experience has been that politicians are likely to listen to you more if you're an organization that has been providing some sort of support and services to people who've experienced problems, because that puts you in a position to then be able to talk with authority about the problems that exist within a system. It enables you to talk about the stories of people, as we've been saying earlier. I well remember getting the first national stroke strategy agreed in England, where there'd been all the evidence, there'd been everything, and we'd been to see the minister a number of times. We went with top medics along with patient representatives, had meetings in the minister's office and so on. And in the end, it seemed that the minister was saying, well, there are so many demands where I'm still not sure that I can press forward with this because there are other things that we can spend money on and so on. So in the end, the way we actually did it was we got the minister, who was a woman of childbearing age. We took her to a stroke unit where a similar person, a woman, had just given birth, but had had a stroke whilst she was giving birth. And the minister was paired up to talk with this woman. And this woman, the patient, she of course burst into tears, saying the problems she's got, having had a stroke now, and she's got a young baby and all the rest of it. And, you know, that was the turning point in terms of getting a national stroke strategy. The emotional flood that went through the minister at that point, you could see it. She was saying, I am the only one here who can make something happen, who can solve this sort of problem for this woman and countless others like her. I can see now why I must do something. And it was no longer numbers on a page. It was no longer treatises on evidence and all the rest of it. It was a human response to a crisis. Something has to be done. You know, I don't know whether that can be done in all circumstances, but what I would say is, if you cannot engender emotion and stories into your campaigning, then you're probably not going to succeed when there are so many options as to what politicians should do.
Yeah.
And, you know, we sort of plan for those sorts of things, but you can only plan for them if you've built up, I think, to a certain point. You know, get yourself a helpline where people who have had these problems are phoning in, and you can give them support and advice, and then collect their stories, see if they'll become or prepared to have their story used for campaigning. You know, you have to be able to demonstrate that there are real issues, real problems out there. And if you can do that, then people will start listening to you.
So when you started out on the journey for a stroke strategy, from start to finish, I presume it was a number of years. It wasn't something that happened overnight.
No, I mean, we were the stroke as such. I was there for, I think, 14, 15 years. It was a long haul. It was something that had to be built painstakingly, you know, month by month, year by year, getting great people around who were good at what they did and did it, you know, having people who really cared. We had something like 250 services on the ground, you know, helping people who are stroke survivors and their families. That gave us incredible clout with the politicians when we went in to talk about what's going on in people's lives who've had a stroke. You know, we could talk from all sides of the country. We knew what was going on because we had services on the ground. I'm quite sure that when you get to that size, you can become very influential. And the real job is to not lose sight when you're small of the fact that if you're just running one support service, one helpline, that is the step. Those are the steps that have to be taken for getting those stories and understanding what's happening. Because if you haven't got those things, nobody will give you credibility that you really know what's going on.
It could be disillusioning to hear, though, that an organization of the size that you had, it took so many years to to move, legislation for a strategy. Is the message that, look, there are no quick wins here. It's in advocacy. It's all about slow, painstaking, step-by-step agitation.
No, I think there can be some quick wins, because if one thinks about it now, there's a lot of countries across Europe that haven't had stroke units in place. It's much easier to push down those barriers, because the politicians and the people who run in the medical systems there feel that they are outliers, that maybe they ought to be doing something now. So when things begin to go, we should sing praise of the big ones who've maybe made things going forward. I mean, I always use the examples of the Scandinavian countries who are in advance of the rest of Europe, and I would say, why is it okay for these things to be in place in those countries but not in our country? So you can, being behind sometimes can make it a little bit easier than the people who are right in the front, because they're having to knock down every barrier that's in front of them.
Trying to address some questions that are coming through to me. One is, you made reference earlier to the role of clinicians. I think it was when you were with the National Stroke Association. So any words of advice on the importance of, or the methodology of engaging with the clinical community from a patient organization perspective? How important is it? What are the best ways to optimize that engagement?
Well, I think that working with clinicians is absolutely essential. There are clinicians who are only interested in their research, and they don't see the point of patient campaigning and advocacy. But there are also many clinicians who are working day by day with patients, and they see the problems that flow when things are not quite as they should be. And it's those people who can be absolutely wonderful allies in terms of when you go in and argue. They have the experience of being inside the system and knowing the barriers and so on that are there. You can actually work with clinicians to take things forward. I'll be honest, some clinicians, maybe require a bit of encouragement and education to actually get on board with the fact that patients should have a voice. But I think the days when consultants felt that their knowledge was so much greater than all of the patients have gone. I think that the medical schools are now turning out a lot more doctors who are sensitive to the engagement and involvement of patients. And of course, many patients are, for good or bad, going on the internet and actually looking up their own symptoms and issues and coming with ideas to the clinicians. So it's not just those clinical issues. We found that clinicians can be a great group of advocates for the things that should be in place post-treatment, because the clinicians don't want the people to be coming back again with similar problems. So if we're talking about things like secondary prevention, or we're talking about support in the community to enable people to continue to adhere to medicine regimes or whatever it might be, clinicians are aware of these things and will support what patient advocacy organisations are saying. So, this is something that we all need to understand, that partnerships build strength. Stronger together.
Trying to get in some of the questions here. A related one is your view now on the changing role of patients in the healthcare system. You've obviously seen over the years significant changes. So what do you see as the current state of play, and what do you see as the future for the role of the patient?
Well, I think that most medical systems now are moving towards having more formalized ways of getting patient opinion. And it's becoming more sophisticated in terms of that. So I can remember way back when people would come out of a unit in hospital and they'll be asked, was your treatment good? Was this or that? And of course, nobody wanted to be rude. Well, or maybe this is just a British thing. People didn't like to be rude about people who had done their best for them. So everything was always excellent. But there are more sophisticated ways now of actually trying to get out of patients what actually happened while you were there, what hasn't been done correctly, collecting data from patients across the board about maybe what was missing, rather than just asking, is what was done good, actually trying to work out what would have made it better. So yes, there are all sorts of things, but I think that also I look in the stroke world now, and we've achieved things in stroke strategies whereby there has to be a review 6 months after treatment, 1 year after treatment, formal reviews that enable patients to have some reflection, to talk to other people, to find out maybe what should have happened and what didn't. And in this sense, patient advocacy organisations are critical, because we should be really empowering people to say what they think, and to give them ideas as well as to what could have happened, and say, if you had a choice, would you prefer this or would you have preferred that? Because if patients are not empowered with knowledge and with a voice, then things will not improve.
We're listening to a conversation which you were part of some time ago, and you made reference to the fact that your journey through the stroke advocacy, that there was this sort of constant struggle to bring stroke to a level of parity with cardiovascular disease. Can you talk a little bit about that? Because I think it gives some insights for us, because in the cardiovascular world, what we're up against is, I guess, other disease areas which are more prominent or more organized. So what was it like from the stroke perspective, and how did you manage to level the playing pitch?
Well, as an ambassador for stroke, I would still argue that the pitch is not yet leveled. But I think that there are all sorts of issues about the history and the sociology of medical systems, so that you get groupings of experts in particular areas of medicine that are being resourced and therefore become professionalized and become more powerful over time. And those groupings, have a strong voice, and they have a strong voice, which leads eventually to strong patient organizations growing within those spheres, and other spheres being starved of resources, starved of awareness, and starved, frankly, of patient organization as well. So you have to first of all recognize that. Now, I've never been a person who said that the way we should go out there and say, do you know, 3 times as many people die, women die of stroke as die of breast cancer. So why the hell are you giving any money to breast cancer when it should go to stroke? The thing is, you cannot say that one death is more important than, or less important than another. What we just have to recognize is that the research and the issues around stroke were Johnny-come-latelys in the medical world. So we have to argue our case through the stories of what actually happens to people when they don't get the treatment they need. and show what happens. And you know, it's a very, very difficult thing to do when you don't feel you're getting a voice. But people by people, you have to make contact with key decision makers within systems who may be a little bit one step removed from all the noise around the powerful interest groups and all the rest of it, because they understand that they're meant to be creating more equitable systems, and you have to actually talk to them and advocate to them. And don't do your public spats with other diseases in the public arena, because it does nobody any good to do that.
Yeah, that's a very, very important point, and it may surprise you that, and I fully get the challenges of, you know, stroke in terms of, certainly in terms of investment in service, stroke versus cardiovascular disease. But it might surprise you though to learn that the Global Heart Hub is only formed since 2019, and prior to the Global Heart Hub, there actually wasn't any alliance of heart patient organizations. And as we're building this alliance, we're realizing actually there aren't many heart patient organizations. And that, I think, is from our point of view in the cardiovascular and the heart community, one of the challenges when you compare heart to, let's say, cancer or rare diseases. And rare diseases, as the name suggests, are rare. Yet that community is so activated, so connected, so powerful. So we definitely all have learnings there. Conscious of time, I'm going to take one or two more questions, and I know you'd like to share one or two slides, and we might close with that, just as a sort of a promotion and awareness of SAFE, Jon. So one question comes in: how can you persuade patients to cooperate and come forward and tell their story? This is in the context, I think, of you know, trying to build your profile and build your storytelling. How do you get patients to tell their stories? Because very many patients feel, you know, oh, I don't want to do that, or I'm too reserved, or, you know, any particular tips on that?
Well, both my mum and dad had strokes, and both of them didn't want their stories to be used and didn't want to get involved in any way. And I was saying, come on, I'm your son, you know, surely you can give us a hand here. And they were saying, no, don't want to do it, because, you know, people are struggling with whatever the consequences of their situation is. And, you know, that's a starting point. I think that there will be only a small percentage of people who are likely to come forward, because these are major life-changing events, and it's unfair to expect everybody to say, yeah, you know, I'm gonna really get out there and do stuff about this, because they're too busy surviving, as it were. But there will be people who have a great sense of injustice, maybe, about the way that they've been treated. There'll be people who feel that what's happened to them, they want to share that experience to help other people on a people-to-people basis. I think people are more likely to come through if you as an organization have done something to help them. You know, it's people help other people. You know, we've been saying for some time, I keep saying it, people by people. If you're kind and you're caring and you're good with people, then people want to give something back. Build relationships, you know, and respect.
Yeah, I think that's a great answer. And I don't know that I mentioned that at the outset in introducing you. It was ironic, tragically, that you were working for a stroke association and both your parents had a stroke. So very, very challenging. But I think it's a great answer because it is a challenge all patient organizations encounter. How do you engage? How do you get people to tell their stories? And I think the piece about building relationships and trust, that's really what it's about, isn't it? I'll take maybe one final question then, Jon, maybe ask you to close by telling us a little bit about SAFE. This question goes back to the issue about, you know, patient organizations engaging with clinicians. And in some countries, and we know this from our own work, many clinicians are either suspicious of or skeptical of patient organizations and patients. and they certainly detest the term expert patient. And there's a number of questions on this. I'm just trying to summarize it into how do you persuade or influence the clinical community to cooperate? Like, what are the key selling points that you might deploy?
Okay, well, one of the things that I think we've learned through partnerships with clinicians is that when it comes to advocating for more resources or a greater understanding of a particular area of medicine, there's often a lot of frustration from clinicians that they can't get as fast a progress as they would like. And, you know, one of the ways of breaking that deadlock is not to say we as patients know better, but we as patients want to stand beside you in actually advocating for those issues. But, you know, it's about building that relationship with those people so they actually understand that there is a purpose to patient organisations, which is not to knock the medical profession, but it's actually there to look for improvement, which benefits the medical profession as well as patients. Now, that can be quite difficult if there's a degree of, I wouldn't say hostility, but you know what I mean. It's that sort of sense of skepticism about what patients can say or do. But, you know, there are plenty of examples everywhere now about how patient organisations have been crucial in actually making a difference in terms of improving resource allocation. And that's why, Neil, you know, creating alliances where information flows from one organisation to another, it's about having those examples to hand and being able to show those examples. And in my experience, that sort of problem tends to exist more in Eastern European and more rudimentary medical care systems than it does in advanced systems where, you know, the medics are now accepting that the patients have some sort of role to play. Yeah,
very good. Conscious of time, Jon, would you like to share for the last few minutes a few slides there, just as you are a patient ambassador for SAFE, and give you this platform just to tell us a little bit about SAFE?
Okay, well, I just wanted to start off by saying that SAFE started with only 6 organisations. So there's a couple of slides here, Neil, which show how those 6 organisations have spread all over Europe the idea that there should be stroke support organisations in every country. And in many ways, we've got more than one organisation in a number of countries. And people have said to me, well, how are you going to sort that out? And I say, well, it's not for SAFE to sort out. That's for the people in their own countries to sort out how they're working together and so on. And, you know, if we take the example, for instance, of a Stroke Association UK and different strokes have tended to focus on the issues around working people who've had strokes, whereas the Stroke Association is much more broad brush. So people find their own areas of expertise and their niches in terms of what they want to do with particular things. But it's been a long ride, and this is a slide that shows SAFE and some colleagues from the European Stroke Organisation, who are the medical people, actually presenting in the European Parliament. There had been no piece of research that covered the whole of Europe. Is strokes going down, up? Is it better in one country or worse in another? And it was SAFE working with a group of about 8 commercial organisations who funded the research, which put together the definitive piece of work on what the burden of stroke is across Europe. And this is a whole panel, multidisciplinary, all different organisations, medics, patients, presenting the findings of that research within the European Parliament. So I think that starting from nothing, then 6 organizations, now 34, and having the ear and the voice of the European Commission and European Parliament shows tremendous progress. What's actually been worked on at the moment is what's called the Stroke Action Plan for Europe. It's about saying to each national government, this is what should be in place in terms of a national stroke strategy. And to reflect on one of your questioners, up until about 2-3 years ago, we were never able to get the medics to accept that within a national stroke strategy, there should be a whole section on supporting people after their diagnosis, after their treatment. And we're very proud that there is a whole chapter of the Stroke Action Plan for Europe now, which deals with many, many, many of the issues with regard to what should happen to stroke survivors once they've been discharged from hospital, once they've left rehabilitation, the fact that they should not be forgotten and left to die in the community, that there needs to be ongoing support. So it might take a long while, but progress does occur, and you need a comeback passion, commitment, and the generation of resources to do all of that.
What a super way to finish up, John. I'm out of time. Not too bad. 3 minutes over. Can I say it's been an absolute pleasure, as you've given us a huge amount of food for thought. Your experience has been phenomenal at a personal level, and in the context of Global Heart Hub. I hope we can remain connected, because there are very strong similarities between what we're trying to do Global Heart Hub wise and what SAFE is doing. So I'd really love to chat to you more about that. There were many more questions which we didn't get to. Thank you so much for your time today. Thank you to everybody who joined us. I hope everyone has enjoyed this conversation and has gone away with something that's been inspirational for their work in patient advocacy. That's it for today. The date for our next Inspire series has not yet been finalized, but everybody on our mailing list will be notified. And of course, we will be promoting it on our social channels. And it will, as usual, be about 2 months from now. Thanks very much, John. Really appreciate it. I also want to thank my colleagues, Olive, Jackie, and Mariana, who in the background have put this together over the last number of weeks. Take care. Thank you.